Okay. So we were talking about stroke volume, and we said that afterload, which occurs where? Where is afterload anatomically? Yeah, arteries. Yeah, arteries. Yeah, vessels. Afterload, if afterload increases, it decreases stroke volume, right? And then the other stuff that we talked about last time was all related to the volume in the ventricles immediately before contraction. So keep volume in mind, okay? And so preload is directly related to volume, but then there's also the fact that volume in Starling's law. Starling's law says that if you stretch the cardiac muscle cells, they'll actually contract better, which is also volume dependent, isn't it? Stretching the cardiac muscle cells. So please note that all of these things are related to volume. And they're related in a couple of different ways, because skeletal muscle pump and respiratory pump aid in venous return, which of course causes more atrial pressure, which causes more preload, right? Filling time is related to heart rate, right? But the next one that we haven't covered yet is ventricular contractility, and that is different than you think it is, okay? The name doesn't quite imply exactly what it does, so let's figure out what it does. So ventricular contractility this is the important phrase, holding volume constant, causing the ventricular walls to contract harder, okay? So it is not related to EDV, not at all, okay? Not related. You don't have to change it now, okay? So here's what you probably haven't been told before. I don't know why we don't teach it in anatomy, but we never do. Watch. Stop talking. Watch. Notice that the parasympathetic nervous system only goes to the SA node and the AV node, just the conducting cells, but the sympathetic nervous system goes to the SA node, the AV node, and the wall of the ventricle. So when the sympathetic nervous system stimulates the heart, we've always told you it increases heart rate. What we never told you is that it also increases strength of contraction just via nervous system. And that is holding volume constant. Yes? Okay. Got it? Okay. So that's independent of how full the heart is. The sympathetic nervous system can and does cause both stroke volume and heart rate to increase. Yes? Okay. That's what ventricular contractility means. It doesn't mean Starling's law. Starling's law is volume dependent. Yes? Okay. It is independent of volume. Is that good? Okay. All right. So that's what ventricular contractility is. It basically says that the sympathetic nervous system increases the strength of contraction, not just the rate of contraction. Damn you. It's like the internet is not hooking up today and it's pissed. I'll just turn it off in just a second. I'll try it one more time. So when you're exercising, remember cardiac output equals heart rate times stroke volume. What I'm telling you is that when you exercise, you hit both. And you get a pretty massive increase in cardiac output. Yeah? And now we'll do heart rate. Okay, so ventricular contractility at a given EDV, holding the volume constant. Son of a... Is that really going to happen today?
Contractility is the constant volume, but increased force.
Yes, exactly. Sympathetic nervous system. It's nervous system related. Okay, so now the question is relatively obvious. Hopefully you know the answer already before I ask it. If stroke volume falls dangerously low, like when you have a heart attack, right? Excessive bleeding, weak myocardium, atrial fibrillation, which is what I have, it's going to really drop your stroke volume. But you need to maintain adequate blood flow to capillary beds. How does your heart compensate? Beats way, way faster to maintain cardiac output. Yeah, and then you'll bleed to death if there's a hole. All right. But, and so, of course, why would you do that? Why would you do that when it seems counterintuitive? Because what is the overriding function of the cardiovascular system?
Oxygen is nutrition and capillary beds.
Capillary beds, exactly. The capillary beds win. They are the drivers of it all, right? Even if you break the whole damn system, you were going to die anyway if you didn't get an adequate blood flow to capillary beds. Okay, so did we do the last thing, pair share? We did the last part of the second one? What? Okay, so let's just do that real quick. I want you to be fast though, okay? We got crap to do. Okay, so we're finishing up stroke volume. right? This one? Decreased stroke volume. I want to know. And we already did the first part of that, so you can talk to each other now.
Okay, so let's take the record decrease. So increase the return to the atrium will increase the stroke volume because of the excess, increase blood coming into the heart. So it's not that would increase the stroke volume. Increase strength of ventricle. Yeah, that will increase because we're going to force it to go. It's going to increase stroke volume, and then increase pressure in the arteries in the heart. If there's pressure increase in the arteries, that's going to cause it to go slower because there's more pressure. It's all pressure. So there's less pressure below. Talks about when there's more blood volume and it opens up, that's it stretches and it's going to increase the stroke volume.
Oh, I see that enough right
It's just because you're busy. You would probably like it if you were busy. Yeah.
I like all the little doodads. I'm a mechanic. I took watches apart when I was like 7 to try and see how this works.
Oh.
I'm that kind of person. I'm a mechanical person.
Oh, yeah, then.
We want to square. Let's do this.
Yeah, I know.
So you're an experimental person. She's a mechanical person.
Well, it's the
So,
medicine thing.
so
Yeah.
let's swap. Because the drug part.
11 people.
And the synapses and all that, where you do the drugs you like, and I'm like, I'm going to struggle with the drugs too. I'm like, I don't trust.
Increased stroke volume out will not directly impact venous return. Venous return is primarily independent of what the heart is doing, with the exception of the fact that the heart creates the pressure in the whole system, but it doesn't impact venous return directly. Yeah, because by the time you dissipate through the capillary, the heart doesn't really cause any pulse pressure in the veins, right? Yeah? Okay. Okay. Last 3 people. Go, 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 go. 5, 4, 3. There we go. Okay, what's the answer?
C.
The answer is, oh, you look at you. Almost all of you got it. Okay, so let's address this first of all to make sure that everybody actually gets it. So all of these factors do impact stroke volume. Increased venous return to the atria will, of course, impact what's in the ventricles, correct? Can anybody tell me why this is an incorrect answer? Increased strength of ventricular contraction. Will that decrease stroke volume? And if not, why not? Try to explain it. Because I already did it and apparently it didn't work for 2 of you. Go ahead.
Because with more contraction, you're increasing the flow out. You're able to squirt more out.
Right, exactly. So if your ventricle contracts harder, it is going to put more blood out. So increased pressure in the arteries near the heart. What is the word for that? Afterload. It is afterload. And so the pressure that you're pushing against, if it's the difference in pressure between 2 points, right? And the ventricles generate X amount of pressure and this amount of pressure is double what it was before, then you're going to have less leave, right? The delta P is less. And then increased blood volume in the ventricles, that is directly related to EDV, right? Does that make sense? Everybody good with that? Okay. All right. So, okay. So what else? All right. So now, of course, we just have to do the factors that are impacting heart rate, but this is quick because you already know it, right? We just have to add a couple of little tidbits to it. But you primarily know that, of course, your heart has an inherent rate of depolarization with the SA node that's about 100 times per minute. But then once you get it started with the SA node, you can apply the gas as the sympathetic nervous system. You can apply the brakes, which is the parasympathetic nervous system. And you know the neurotransmitters that those use, so this will actually be relatively quick for us to go through. So let's look at our concept map real quick and start talking about heart rate. So the things that impact heart rate are, my computer just wants to be a jerk today. Okay, the things that impact heart rate are primarily the rate of depolarization in the pacemaker cells, which is both inherent and then can be changed with the autonomic nervous system, right? Which sympathetic and parasympathetic innervation, which is what the autonomic nervous system decides to do. You with me? Okay. So those things actually impact heart rate in a way that is predictable. In addition, we're actually going to see that there are a couple of hormones that can impact heart rate, and we'll talk about those. It's not that hard. Okay, so medulla oblongata gets to decide what's going to happen to your heart rate. It decides based on input that's coming in from elsewhere. For instance, cerebral cortex says tigers are scary, tells the medulla oblongata that we need you to do something to the heart, and the medulla oblongata goes, I got you, bro, and then sends out an impulse to, of course, the SA node, increasing the rate of depolarization in the SA node. You with me? Yeah? Okay, so the medulla oblongata controls cardiac muscle contraction. It also controls vasoconstriction and vasodilation, but listen very carefully. When it does it with the medulla oblongata, it's not local, it's systemic. Okay, so stick with me. And what you're going to do with the hormone, or if you do something systemic, never undo what you did at one effector with the other effectors. So if, for instance, the medulla oblongata decides that it needs to increase heart rate, what should it do to vessels systemically that would not undo what you just did to blood flow? Constrict. Yes. Yes? I'm not saying it constricts everywhere, but more constriction than dilation, because if you didn't do that, think about this. If you just increased your heart rate but then did systemic vasodilation, you would have just increased blood flow and then decreased blood flow. Yes? Okay, so again, this is systemic, not local. So systemic constriction tends to be trying to hit pressure. Local constriction tends to be trying to hit resistance. You with me? Okay, now they both have impacts on each other, and I acknowledge that they do. But what is the point of local vasoconstriction, more resistance, decreased flow? What is the point of systemic vasoconstriction, more pressure, increased flow? Yeah? Okay, all right, so there is in the medulla oblongata what we call the medullary cardiovascular center. It's not that hard. Part of it is hooked up to the sympathetic nervous system. We call that part the cardioacceleratory center. Makes sense, right? Part of it is hooked up to the parasympathetic nervous system. We call that the cardioinhibitory center. And this picture has kind of both of them. Medulla oblongata gets to decide. The medulla oblongata will send an impulse directly through the vagus nerve or down to the thoracic region and then out through the sympathetic nerves. Sound familiar? Okay. And by the way, this is just gray matter nuclei within the medulla oblongata. You didn't learn the names of all of the individual nuclei, but it's two different nuclei. Cardioacceleratory center and cardioinhibitory center. Okay, so what happens if you decide to activate the cardioacceleratory center? Well, you know this. It sends action potentials down to sympathetic neurons. The sympathetic neurons go to the SA node and the AV node. And then the sympathetic neurons, you should know this, sympathetic neurons, we're right here, will secrete what neurotransmitter at the effector? Norepinephrine, yeah, primarily norepinephrine. And they secrete norepinephrine at the effector, and it increases heart rate. It also has another effect that we're not talking about right now, but let's acknowledge it. We are in the heart rates discussion, but of course, when you release norepinephrine, you also increase ventricular contractility, yes? So sympathetic nervous system does two things related to cardiac output, yeah? Okay, and what type of receptors are involved? Adrenergic. And specifically, by the way, they're beta adrenergic, which is why beta blockers are a thing. And we'll talk about those later. Okay, administering epinephrine clinically has the same effect. So epi hits both heart rate and stroke volume. Everybody okay with that? Okay. But what if the medulla oblongata, cerebral cortex says, not a tiger, dude in a tiger costume? Actually, it's my favorite person in a tiger costume. This is fantastic. And then, so you do not need to activate the sympathetic nervous system. You need to activate the parasympathetic nervous system, right? I don't need any more blood flow. I was wrong. So in this instance, what happens is part of the medullary cardiovascular control center, called the cardioinhibitory center, is connected to the parasympathetic nervous system through what nerve again? Vagus nerve. Yes, it's the vagus nerve. The vagus nerve is in control of most of the ventral body cavities, parasympathetic control. So it sends an action potential via the vagus nerve to the SA node and the AV node, but please note, not hooked up to the ventricular wall. So it has no direct impact on stroke volume. Has a direct impact on heart rate, no direct impact on stroke volume. Yes? Everybody okay with that? Okay, so what it's going to do is what it's doing right now, because I don't think your heart rate is 100 beats per minute right now. Even mine isn't, and I'm teaching right now. The parasympathetic neurons secrete the neurotransmitter what? Acetylcholine. It decreases heart rate, no direct impact on strength of contraction. What type of receptors are involved? Cholinergic, yeah. Damn class just keeps repeating itself. Don't you hate it? Okay, so what?
It's good.
It's actually good. It like helps to reinforce it, which is why I decided to put all these blanks in here. You're like, oh, God damn it, Melanie. I'm going to write it down for the 56th time. But I figured out that students actually like that. So normally what's going on with you right now, over the course of a day, parasympathetic innervation to the heart would dominate, right? It's most frequent. Sympathetic is infrequent, like when you get up and run to your car or whatever and you're running late or you see a tiger or whatever, then, or you exercise. Then sympathetic goes on, and then you go back to the default, which is parasympathetic is most of the time slowing down your heart rate. Go ahead.
Why do we, if like we're pretty consistently having parasympathetic innervate the heart, why did our pacemaker cells evolve to be 100?
Fantastic question for which I do not have a reasonable answer. If I gave you one, it would be just spitballing, and I don't even have a good spitball for this one. But I would love for somebody to come up with a great answer for that. I get curious about that stuff too. Like when I run into something that just doesn't seem like it would have evolved that way, I'm like, WTF, evolution. Give me the answer to this one. Like the G protein receptors. What the hell, people? I need an explanation. If I believed in an afterlife, I'd be like, I have questions. We are talking after. But I don't.
A bunch of groupies.
And they'd be like, sorry, I don't have time. So now, autonomic regulation of heart rate is initiated not just by tigers and exercise and chill, but by some other things we're going to talk about in just a second. So you are not just monitoring fight or flight or feed or breathe. That's a simplistic explanation. We will see that you're also monitoring your pressure to figure out when to turn it on. You're also monitoring the chemical content of your blood. But we'll get to that in just a second. It's not that bad. Okay, and then hormonal control of heart rate. So we know that the nervous system can control heart rate, but there is also hormonal control. One of the hormones is obvious, epi, right? Epi will actually cause the heart rate to increase, yes? But one of them you haven't probably thought about before, although I put it on the video. Let's do epi. Where's epi secreted by? Adrenal medulla. You guys are so smart. You know so many things that you didn't know before. I am impressed. And what epi does hormonally is the same thing as it does as a neurotransmitter to the heart, that is, increases heart rate and stroke volume, strength of contraction, yeah? But then what about thyroid hormones, T3 and T4? Those increase the metabolic activity of all tissues, including the heart. So is it dramatic? No. But is it persistent? Yeah. So what I'm saying is that if you were hyperthyroid, your resting heart rate would probably be higher. Yes? And if you were hypothyroid, your resting heart rate would probably be lower. So it's not like a regulatory mechanism. It's just like an impact of thyroid hormone, is that it impacts the metabolic rate of all tissues, including cardiac muscle. Does that make sense? So increases heart rate for a much longer duration, but not as dramatically. And you're not really using it as a regulatory mechanism, but it will impact your heart rate. Go ahead. You got a question on your face.
No, I was just making a connection with what the test results were for my mom when they tested
Oh.
stuff for this.
Oh, yeah. Yeah. She was hyperthyroid, right? Or Graves, right? Yeah? Yeah, hyperthyroid. What was her heart rate? Higher?
It was higher. She overreacted, but it was higher, and they were like, "Well, just be mindful. We'll be checking this."
Yeah.
later on."
I mean, there's a whole range of healthy heart rates, right? Okay, so what are some other factors that influence heart rate? I didn't put them on here because, you know, it was messy enough. But other things can influence heart rate, and you guys probably knows. Temperature increases heart rate because temperature increases diffusion rate. So at slower temperatures, the calcium and sodium diffusion into the pacemaker cells would be slower, yeah? And so your heart rate tends to be a little lower at lower temperatures and a little higher at higher temperatures, just because of diffusion. Good? Okay. But the other thing that's true is at lower temperatures, your metabolic rate is also lower, so your oxygen requirements are lower, so a lower heart rate is fine at lower temperatures, yeah? Okay? Emotions can also impact heart rate, yeah? Both via the autonomic nervous system and also via stress hormones. So there is an emotional connection. Anxiety is going to increase your heart rate, but it's not magic, right? It's not, nothing is magic. You just don't know the science yet. So what happens, of course, is anxiety will cause both neurotransmitter release and hormone release. And those neurotransmitters and hormones can cause your heart rate to change, yeah? Ions. If you have an ion imbalance of any of the ions that are related to cardiac muscle contraction, it can impact either the rate or the pattern of your cardiac muscle contraction. So too much, too little potassium, too much, too little sodium, too much, too little calcium. All of that could do it. Does that make sense? Okay, and we don't need to go back to how, but you guys remember that hyperkalemia can kill you because it stops your heart. Hypokalemia causes cardiac arrhythmias. Calcium are a little more complicated. And then endurance training. So what happens when you start endurance training? Why was Lance Armstrong such a freak of nature? Well, first of all, his genetics predisposed him for that. But then, in addition, he didn't just sit on the couch and expect to be a champion. He took drugs. No, I'm just kidding. It's true, though. So what happens with endurance training, which is cardiovascular training over long periods of time, is that you train your stroke volume to be very high so that your resting heart rate can be very low and your cardiac reserve will be big, right? Yeah? And it's really, really good for your cardiovascular system to have infrequent but effective heart rate, right? Infrequent with high stroke volume is much better for the system. So again, at his peak, 37 beats per minute. Resting heart rate, 37 beats per minute. Freaking sloth, man, right? Clinical congestions, clinical connections, congestive heart failure. I want to come back to that one. If I don't have time to do it, I'll put it on a video, but I want to make sure that we get to the stuff that's actually complicated and you need me for. Because I usually only ask one or two questions about the clinical connections, but I ask a whole bunch of questions about the rest of it. Okay, so now I want to talk about how to control blood pressure. But again, this should be pretty okay for you guys because I already told you that basically when we're talking about blood pressure, there's 3 ways to control it. There's vessels, yes. There's heart, and then there's what? Volume, which is kidneys, yes? So let's talk about vessels, heart, and volumes controlling blood pressure. Why do we hear about blood pressure? It's one of the primarily determinants of flow, right? It can be too high, it can be too low, it can be just right, like the Goldilocks thing. Okay, so let's talk about blood pressure. Okay, so extrinsic control of blood pressure. So ways that blood pressure is controlled with the nervous system, extrinsic, right? The endocrine system. Only we get to add in one other external system that's related to controlling blood pressure, which is the kidneys, yes? Extrinsic control is usually nervous and endocrine. In this one, the kidneys are also directly related to controlling it. It's not a very quick fix. We will see that kidneys controlling blood pressure is a little longer, takes longer than the nervous system or even the endocrine system. So, first thing is autonomic nervous system gets to decide on heart rate, yes? We also now know it decides on vasoconstriction and vasodilation. When you are doing heart rate and vasoconstriction and vasodilation together, never undo what you did with one with what you do with the other. And now we are talking about extrinsic, so we're talking about systemic control, right? None of this is local in the story that we're about to tell. Everybody okay with that? So, in addition to tigers, how do we decide when to turn on the sympathetic versus the parasympathetic nervous system? There are some other things that we are actually monitoring, and they include what we call the baroreceptors. So let's talk about the baroreceptors. Okay, so what I have is pressure receptors. Baro implies pressure, right? Like barometric pressure. You with me? I have some pressure monitors in a few places. So think about this before I get you guys into it. I have pressure monitors in the aortic arch, which is really monitoring systemic arterial pressure to where? All of systemic circulation, right? It's really general in the aortic arch, right? Everything but the heart, right? All of systemic circulation. So, and then I have baroreceptors that are more pissy in the carotid sinus. What are those monitoring pressure to? Brain, yes. They do the same thing, but this one's way easier to piss off and much more susceptible to body position changes. Yeah? Does that make sense? Okay. But they're pretty much, they're buddies, only this one is the first among equals, which is what the brain considers itself. It's like, you guys are all equal, but I'm equaler. Yeah? I'm like my favorite thing because I'm the thing that has favorites. Okay, so baroreceptors, which are pressure receptors, what they do is they take sensory input and decide high pressure, send that sensory input, and then the medulla oblongata decides what to do. So you tell me before I tell you, right? If you detect high pressure in the aortic arch or the carotid sinus, you send that sensory input to the brain and specifically get it to the medulla oblongata. And then the medulla oblongata decides on what appropriate output. Choose one. Activate the sympathetic or the parasympathetic nervous system. Parasympathetic nervous system. If, however, what you detected in the aortic arch and the carotid sinus was low pressure, send different sensory input to the same place, medulla oblongata, and it takes that sensory input and decides to do what? Sympathetic nervous system, yes? So let's watch an animation about that. Hold on, stop. My computer is so mad at me today. What the hell is it doing? Oh, there it is. Okay. Okay.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation.
Let's just acknowledge for all of us anatomists that that is not the carotid sinus. No, that's the brachiocephalic artery, and it pisses me off. Okay.
Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata.
None of that is particularly important. Sensory input to the medulla oblongata. The rest of it is just syllables.
As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate.
Okay, so that was putting on the brakes. You with me? But I can also take my foot off the gas. Yes? I'm going to do both. I'm a bad driver. I had my foot on both of them at the same time. I am a bad driver.
Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal.
Good.
If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
Make sense? Yeah? Okay. So that's the carotid sinus reflex and the aortic arch reflex. What do? They do the same thing, only this one is really susceptible to body position changes, right? It's easier to tick off. It has less of a happy, okay range for pressure because the brain doesn't have any room for swelling, yeah? and it's intolerant of ischemia, right? So this one actually probably activates more often than this one, but quite often at the same time they would. Like if your systemic blood pressure was low, they would both activate. But this one might activate when, for instance, you get up too fast, right, and the pressure drops in your to your head, right? If you're like, anybody get that lightheaded because you're low blood pressure? Yeah. Okay, does that make sense to you guys? So these two do the same thing. One of them's a little tweakier, yeah? But then this one I need you to listen to because it's a little hard to understand if you're not listening, and it's totally counterintuitive. Okay, so now I want to talk about the right atrial baroreceptor reflex. Okay, but I want you to think about what the right atrium is. If we do systemic circulation, and I tell you systemic circulation starts in a ventricle and ends in an atrium, yes? Systemic circulation starts in which ventricle? Left ventricle, and ends in which atrium? Right atrium. Okay, so this is back end pressure regulation. Okay, is it monitoring arterial flow or venous return? It's monitoring venous return. You with me? Okay, so now I want you to think about this, and everybody hates it, but it's actually kind of cool once you get it. Okay, so the right atrial baroreflector reflex, there's no animation for this. There isn't even a picture in it. It responds to venous return. So what I have now also is baroreceptors in the wall of the right atrium and the superior and inferior vena cava. With me so far? And increased venous return to those will cause stretching. And now I need to figure out what to do with that information. Let's think it through. If I have increased venous return to the right atrium through the superior and inferior vena cava, I'm going to send that sensory information to the medulla oblongata, and it has to figure out what to do with that information. So I'll give you two choices. Increase heart rate, decrease heart rate. Increase heart rate. Does that make sense to you? Because if you decrease heart rate, what you're going to do is you're going to back up the blood flow, yes? So what should I do if I have more venous return into the heart? More ventricular contraction to get it out, right? But that's exactly the opposite of arterial baroreceptor reflexes. Arterial baroreceptors are monitoring the output. So if I have high pressure, I'm going to slow it down. It's too high, right? But atrial are monitoring the input. If I have high pressure, I need to get to work, man. You're like, you are the holdup ventricle. Get to work, right? That's what's happening with the right atrial baroreceptor reflex. This is back end, right? Whereas the arterial ones are front end. Yeah? Does that make sense? Okay. Questions? No? You got it? Really? Really? For sure? I don't trust you, do you? You're like, if I say yes, will you shut up? Go ahead.
So it increases, does it also increase atrial contraction or just ventricular contraction?
It increases ventricular contraction. It increases heart rate, and so it activates the sympathetic nervous system. And so what the sympathetic nervous system does is what it does, right? Well, so if you send different sensory input, okay, different sensory input, which was detected right here, yeah? That sensory input goes to the medulla oblongata. The medulla oblongata says, whole bunch of pressure in the right atrium. Let's send the sympathetic nervous system out, right? Increase heart rate and also strength of contraction, yes? Increase output to keep up with input. Kind of like Starling's law, but this one's nervous system dependent, and Starling's law was only volume dependent. It wasn't involving with the nervous system. Good? Go ahead.
Does some of that come from the just mechanics of it, where it's like it's fuller faster, and so it will dump into the, like if it's coming in faster, it will dump into the ventricle faster. So
This one is nervous system. It's actually sensory receptors that are present here. Pressure receptors. So if you're asking, is that the reason? Yes. But the actual mechanism is sensory baroreceptors are activated, send the input, and then the output comes back out.
But what I'm asking is, would you also have Starling's law also?
Yes, Starling's law would be happening as well, but Starling's law is ventricle dependent, yes. So right after you did this and you dumped a whole bunch into the ventricles, it would say, hey, I'm both going to do ventricular contractility in the wall, and then also I've got Starling's law going on, right? So they're all working together. They're not working against one another. One of them is just volume dependent. This one is volume dependent in the ventricles. This one's volume dependent in the atria. Okay? All right, so I try not to think about them together because it confuses the crap out of people, but they do happen together. Stop trying to confuse people, Rebecca. Okay, so what could you do, by the way, and just to reinforce, what would you do if, for instance, you detected a lot of stretch in the right atrium, sent the impulse, it said, okay, let's turn on the sympathetic nervous system to get the blood out of there. What would you do that would be consistent with the vessels? You'd actually, no, it's constriction. Yeah. You have to, because this is systemic, right? Yeah. So you got to get the blood out. You got to keep pressure, keep going through the system. So you do vasoconstriction. Even though in this instance it sounds counterintuitive, you would never undo what you just did with the heart with what you did with the vessels. Because if you vasodilated, right, then you wouldn't be moving blood out, right, as well, because you would have dropped the pressure in the system at the same time as you increase the heart rate. Right? So you got to maintain the pressure to keep fluid moving. Again, although it's counterintuitive, when you do systemic vasoconstriction, it's about pressure, and when you do systemic local vasoconstriction, it's about resistance. Okay? So you never undo what you did with the vessels with the heart.
So local, in this instance, if you got tons of blood coming towards the capillaries, it's going to constrict also.
Yeah, but this is not this instance. That's a whole different instance. Yeah, this is systemic. So if you're involving the nervous system, it's systemic. It has to be paracrine if you're involving just local. Okay, now there is another one, and this is actually relatively logical as well. It's called the chemoreceptor reflex. Chemoreceptor reflex, instead of baroreceptors in the aortic arch and carotid sinus, I have chemoreceptors. Okay, and what the chemoreceptors are doing is they're monitoring the chemical content of the blood. So what are they monitoring? They are monitoring oxygen, carbon dioxide, pH. Yeah? Okay. So you guys tell me instead of me telling you. If I detected in the aortic arch or the carotid sinus, do the same thing. This one's pissier. Okay? If I detected low oxygen, high carbon dioxide, or low pH, I send that sensory input to the medulla oblongata. What should it do? Two choices. Activate the sympathetic or the parasympathetic nervous system. Sympathetic. Yeah? It means I have inadequate blood flow in systemic circulation, so I need to increase blood flow. Yes? So that's what I'm going to do. So, and if you detected the opposite, you would do the opposite. So it's the same thing as you expect, but watch, it's going to do the same thing.
Chemoreceptors in the carotid and aortic bodies monitor blood oxygen, carbon dioxide, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. Chemoreceptors in the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen, increased carbon dioxide, or decreased pH decrease parasympathetic stimulation of the heart.
Okay, these, right? You know you're going to activate sympathetic. That's putting your foot on the gas. But let's take our foot off the brake too, right? Does that make sense? That's the parasympathetic.
Which increases the heart rate. Decreased blood oxygen, increased carbon dioxide, and decreased pH increase sympathetic stimulation of the heart, which increases heart rate and stroke volume. Increased sympathetic stimulation of blood vessels increases vasoconstriction.
Good? Okay. Everybody all right? Okay. Okay. And then the other thing, so that was basically nervous system control of blood pressure. Those are in addition to tigers, right? The other way that you can decide to turn on the sympathetic or whatever is exercise, tigers, whatever. But you're also monitoring, now the new information is you're monitoring pressure also, and you're monitoring chemistry. Okay, so that's all nervous system control of blood pressure. And now let's do hormonal control of blood pressure. But hormonal control of blood pressure is going to be relatively familiar to you. So, because we have learned about a couple of hormones before, maybe, I don't know. Okay, so here is how any hormone that increases blood pressure or impacts blood pressure is going to work. Heart, vessels, kidneys, yeah? Again, the rule is always never undo what you did with one with what you do with another. So if, for instance, before you even get into it, if a hormone causes increased blood volume by water retention at the kidney, what could it do to the heart that would be consistent? Increase or decrease heart rate? Increase. Okay. If it causes water retention and increases heart rate, what could it do to the vessels that would be consistent? Constriction. Yes? because we're talking systemically, yes? Because if you dilated, you just undo what you did, okay? All right, so let's look at this. Epi, we know it, it's from the adrenal medulla. The effect is twofold. Causes vasoconstriction, mostly systemic. I'm not saying it causes vasoconstriction everywhere, but more vasoconstriction than vasodilation, yeah? And it also increases cardiac output 2 ways, and we know that, right? Hormonal epi. And the impact on blood pressure, higher or lower? Higher, yes, okay. ADH. ADH is from the posterior pituitary, right? It does, it increases blood volume by increasing water reabsorption, yes? And it also causes vasoconstriction because it's also called, what's its other name? Vasopressin, yeah, ADH or vasopressin. What is the impact on blood pressure, higher or lower? Higher, good. Angiotensin 2, you haven't learned about in detail yet, but you're about to. Kind of comes from the kidney with an asterisk because it actually involves 3 different organs. But it actually causes vasoconstriction, and it also causes aldosterone release. Both of those are going to do what to your blood pressure? Increase it, good. Aldosterone, our friend, yes? Comes from the adrenal cortex, and it increases blood volume by increasing sodium and water retention at the kidney. And what's that going to do to your blood pressure? Increase it. We haven't talked about erythropoietin yet, but you may have talked about it in anatomy. What it does is causes erythropoiesis, red blood cell synthesis. If you got more solids in your blood, what's it going to do to your blood pressure? Yeah. It's not dramatic and it's not quick, but it actually does increase your blood pressure if you have more stuff in it. Yeah, it actually increases your viscosity as well. ANP or ANF, yeah? This is produced in response to prolonged atrial wall stretching, not just when you're exercising, for instance, and it comes from the heart, and it does 2 things. It decreases blood volume by allowing sodium and water loss at the kidney, and it does what is consistent at the vessels. What is consistent? Dilation, not constriction. And so this is the only one that does what to your blood pressure? Decrease, yeah. So it's the only blood pressure decreaser that we have hormonally, or that you're going to learn hormonally. Everybody okay with that? So that's not bad because you've already done most of those. Okay, and then the last extrinsic control of blood pressure is the kidney control of blood pressure. So the kidney has this sort of relatively direct control of blood pressure by just determining blood volume, right? Everything you pee came out of your blood plasma, yeah? Everything you decide not to pee stays in your blood plasma, right? So that's just sort of the direct relationship between the urinary system and the cardiovascular system. So it alters blood volume by deciding how much sodium and water to retain, how much to lose, right? So that's what your kidneys are doing for you. Interestingly, before you get to college, nobody even really tells you that your kidneys and your cardiovascular system are intimately related because you always just think of your kidneys as waste, right? They're just getting rid of waste, but they're actually really, really important for cardiovascular physiology. Okay, and then the indirect mechanism is renin, angiotensin, aldosterone system. It seems hard, it gets easy, and we talk about it 3 times. Okay, so the renin, angiotensin, aldosterone system, how this works is it's a negative feedback, so I'll go ahead and give you a heads up about that. And if I detect low blood pressure at the kidney, and specifically it's in the juxtaglomerular apparatus. So juxtaglomerular cells in the wall of the afferent arteriole, for those of you who know that anatomy. Low blood pressure at the kidney, afferent arteriole. Okay. What will happen is these juxtaglomerular cells will secrete a hormone called renin. It's not renin because there is a hormone called renin that comes from the gut. I mispronounced it for years before somebody told me, you're saying the wrong one. So renin, as in renal, right? So renin into the bloodstream. And what renin does is renin interacts with an always present but inactive plasma protein that's just always around. And this inactive plasma protein is called, so renin interacts with an inactive plasma protein called angiotensin-O-gin. We'll break that down and make it make sense to you. So angio as in vessels, tensin as in pressure, genesis. So keep that in mind. So this is actually made by the liver, and it's always around, but it doesn't really do anything unless renin's around. So when angiotensinogen gets activated by renin, it forms angiotensin 1, which doesn't do anything unless it's activated by another one. ACE. ACE inhibitors, yeah. ACE, so ACE just stands for angiotensin converting enzyme. So what it does is converts angiotensin 1 to angiotensin 2. Okay. Strangely, I don't understand this part either. ACE comes from the lungs. What the hell? I don't know. So that's why when I told you that angiotensin 2 is from the kidney and put an asterisk by it, because I don't know where it's from, do you? Because like renin is from the kidney, but this is from the liver, and this is from the lungs, and then you get the hormone. Yeah? So why the hell did you get this hormone at all? Because angiotensin 2 is the most powerful vasoconstrictor in the body. Okay? So angiotensin 2 does two things. Vasoconstriction, which will help solve the original problem, correct? Yes? But it does one more thing. It also goes to the adrenal cortex and causes it to release aldosterone. Okay, short-term solution to your problem, longer-term solution to your problem. Yeah? So the net effect is, if I detect low blood pressure in the kidney and activate this, what do I do to the blood pressure that goes everywhere, not just kidney? What does it do? Yeah, it increases blood pressure by two mechanisms, causing aldosterone release, yeah, and also causing vasoconstriction. This is called the renin-angiotensin-aldosterone system. Everybody okay? Okay. So the biggie is right here. So one of the treatments for hypertension is ACE inhibitors. Do you see why that would work? Yeah? It's actually ACE antagonists, by the way. Yeah? And they use them to treat hypertension because it blocks the release of aldosterone, which will allow you to lose more fluid, and it blocks vasoconstriction. Yeah? Cool. Okay, ACE inhibitors will actually work that way. Everybody all right with that? Okay, so again, I'll come back to these after I'll come back to the clinical connections after I do the other stuff. Okay, so last actual material before we get into the clinical connections is the cardiac cycle. So the cardiac cycle is, it's actually easier than you think it is. Some of you cover it in anatomy and some of you don't, but it's not hard to understand, really. So here's what the cardiac cycle is, big picture. The cardiac cycle is trying to piece together the electrical and mechanical activity of the heart. And what do I mean by electrical? I mean when the SA node depolarizes, when the AV node depolarizes, when the Purkinje fibers fire. Everybody with that? Okay. What do I mean by mechanical? Mechanical, I mean the pressure changes and the valves opening and closing. Okay? So I've got a few things that I have to sort of keep track of. I have to keep track of chamber contraction and relaxation, yeah? And I have to keep track of valves opening and closing, right? But it's all pretty logical after you've gone through it the first time. Because don't you kind of understand what the heart's doing anyway? The only misconception that people have is that quite often people get all the way through anatomy and sometimes all the way through physiology, still not understanding the reason that the AV valves, bicuspid and tricuspid, open and close. So hopefully we're going to get rid of that today. If we do, I will be delighted because I don't want you to continue your career by having that misconception. It's a really persistent misconception, and I kind of see where it comes from as well. So the cardiac cycle is the mechanical activity of the heart during a complete heartbeat. It includes chamber contraction, valves opening and closing, and heart sounds. And you can track pressure through the system if you want to as well. So let me see if I pulled that one up. Cardiac cycle. Okay, so the cardiac cycle looks like this, but let's just focus on some easy things first, okay? So what we are going to have is we're going to have 4 phases to the cardiac cycle, but it's a circle, so then you'll start it all over again. So let me show you the big phases, okay? The big phase is ventricular filling, okay? Isovolumetric ventricular contraction. I put ventricular in there so you know what's contracting, okay? Ventricular ejection, and then isovolumetric ventricular relaxation. And then I'm back to ventricular filling, okay? So it's a circle. So what we are going to do is we're going to kind of figure out what the valves are doing in each position, but it's pretty logical. And it's a circle. It doesn't matter where you start in the circle because you're going to have to get back there anyway. So the way that your textbook explains it and the place that the video starts are 2 different places. But after we understand the circle, we'll be okay, no matter where you actually start. So let's look at notes first and then video. Okay, so the cardiac cycle is looking at the mechanical activity of the heart, and then we'll try to go back and put the electrical activity with it. So first off, ventricular filling. Logic question for you. If what I'm calling it is ventricular filling, what is the position, open or closed, of the AV valves? Open. Yes, right? FYI, in a healthy person, you never have both sets of valves open at the same time. So if one set of valves is open, what's the position of the other one? Closed. So you didn't have to memorize that, right? Ventricular filling, AV valves open, semilunar valves closed, good, right? Okay, so with ventricular filling, what is going to happen is blood is continually returning via venous return passively through the superior and inferior vena cava, also the pulmonary veins, back into the atria. Everybody with me on that? Okay, and it's passive. It's primarily due to the respiratory pump and the skeletal muscle pump, right? It's not directly related to what's going on with the heart. So you're getting this ventricular filling. And this phase is relatively long. These are the times of the phases. So we're in phase 1 right now. At the end, one question for you. During ventricular filling, the AV valves are open. But can anybody explain to me why the AV valves opened? Because they've opened and I haven't contracted the atria yet. Why do the AV valves open? That's why they need to open, but what is mechanically responsible for them opening? It's just the pressure of venous return, the passive venous return. If you've got a valve like this, right, you get enough blood on top of it, then the AV valves are going to open, okay? Then at the end of ventricular filling, when about 80% of the blood is already in the ventricles, then I do atrial contraction. Atrial contraction squishes the last 20% of blood from the atria to the ventricles. But even if the atria don't work, like with atrial fibrillation, like I have, 80% of blood flow is still going on, okay? It's not adequate enough so that you can run around the damn room. I will have to sit down when it's going on, but it is not going to kill me instantly. Does that make sense? So atrial contraction occurs at the end of ventricular filling, okay? So it is within ventricular filling. Atrial contraction is a subcomponent of ventricular filling. Okay, so let's think about this. Now I've done atrial contraction at the end of ventricular filling. Logic question for you. Ventricular filling is going to end when what valves do what? AV valves close. Why do they close? Pressure, because I am starting ventricular contraction, yes? Okay, and ventricular contraction pushes on the backs of the AV valves. If you're healthy, they stay closed, right? That's the lub heart sound, lub heart sound. So when those are closed, there is a period of time when the other ones haven't opened yet, okay? So there is a period of time in which I have closed the AV valves because of increased pressure, but I haven't generated enough pressure to open the semilunar valves. This period of time is called isovolumetric, same volume. What? Ventricular contraction, because that's what's going on. The video calls it isovolumic. It's still the same idea, okay? So do you see why it's called isovolumetric ventricular contraction? Logic question, isovolumetric ventricular contraction, which is short, by the way. It's a relatively short period, yeah? It's going to end when what valves do what? Semilunar valves open. Why do they open? Pressure. Pressure is always the answer, guys. It's always the answer for the valves, okay? And that pressure in the ventricles continue to increase because of ventricular contraction, and that will cause the semilunar valves to open, which begins the relatively long period. Do you see how much longer it is? Yeah? Of ventricular ejection. Yeah? And that makes sense too, doesn't it? Okay, so even if you didn't know if the semilunar valves are open, what's the position of the AV valves? Closed, yeah, they have to be closed. Okay, does that make sense? Okay, and logic question for you. Ventricular ejection, which is pretty long phase, is going to end when what valves do what? Semilunar valves close. Why do they close? Pressure. Pressure, why? Because you dropped pressure in the ventricles, so they're low pressure. There's a decent amount of blood in the arteries, tries to flow backwards, gets caught in the cusps. Does that make sense? Okay. So that closes the semilunar valves. This begins a short period in which all the valves are closed and the ventricles are relaxing. This is called isovolumetric ventricular relaxation. Yes? Does that make sense? Okay. And to start the whole damn story again before we actually get into the video, isovolumetric ventricular relaxation is going to end when what valves do what? Atrioventricular valves open. Why do they open? Pressure. Due to what? Venous return, not atrial contraction. Yes? Pressure due to venous return. Does that make sense to you guys? Yeah? Go ahead. Do you have a question, Jim?
The dub noise is the pressure of the semilunar, the
Dub-
blood coming against the semilunar.
Yes, dub noise. So it's lubbed up, lubbed up. The lub is the blood slamming against the AV valves as they close. The dup is the blood slamming against the semilunar valves as they close. So you're not actually hearing anything contract, FYI. You're just actually hearing blood slamming against those things as they close. Yeah, it's cool, right? What? Yeah. Okay, so let's watch the animation. Okay, cardiac cycle. Why is this open? Okay, ready?
Ventricular contraction causes the atrioventricular valves to close.
Okay, he's starting at a different place. Let's orient ourselves. Ventricles are contracting. I just closed the AV valves. Where am I? Isovolumetric ventricular contraction. It's okay though, because it's a circle. We'll get back there in a minute. We're just starting right here. So I now can predict what's going to happen next.
Which signals the beginning of ventricular systole.
Or contraction.
The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk.
What period am I in now? Ventricular ejection, exactly.
Causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole.
Which is called isovolumetric ventricular relaxation. I put ventricular in there every time because I want you to know which chamber is doing what, okay?
Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atria, the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
So we go isovolumetric contraction, ejection, isovolumetric relaxation, ventricular filling. Over and over and over and over and over and over again till you croak. Cool? Got it? Okay, it's pretty logical, don't you think? So the only thing that is challenging is making sure you know the vocabulary, right? So that you can pick out the right word. But do the mechanics make sense to you guys? The mechanics are actually pretty logical. Okay, so the cardiac cycle timing as we get into it. At a heart rate of 75 beats per minute, which is within normal, right? 75 beats per minute is within normal. That gives you 0.8 of a second for each cycle. But what I want to reinforce to you is you spend as much time relaxed as you do contracted, because relaxation is important both for filling and also for delivering blood to the myocardium. So at 75 beats per minute, you spend 1/10 of a second of each 0.8 of a second cycle, 1/10 of a second with the atria contracted and the ventricles relaxed. So the atria don't have to contract for very long, right? You spend 3/10 of a second with the atria relaxed and the ventricles contracting. So the ventricles contraction is longer and stronger, yeah? And then overall, you spend about half the time, 4/10 of a second, with all of the chambers relaxed. Does that make sense to you guys? Yeah, I'm not saying they're relaxing at the same time. I'm saying of an 8/10 of a second cycle, you spend about half of that time with chambers relaxed. Is that okay? Okay, so the last thing on this before we get into the clinical connections is just coordinating mechanical activity with electrical activity. Because you guys did ECGs in lab. Okay, so just simply, we'll just do it the simple way. They also have it here, right? The ECGs are actually coordinated right here. Heart sounds are right here. ECGs are at the bottom. And then this is just tracking pressure and then tracking the position of the valves. Okay, it's not really as hard as it originally looks. The ECG is right there on the bottom. So let's put together what would be happening on an ECG with what's happening with the mechanical activity of the heart. And so the mechanical activity of the heart must be coordinated with the electrical activity of the heart. So for each electrical event, can you tell me the corresponding mechanical event? And then answer questions if necessary. Okay, so if the electrical event is atrial depolarization represented by the P wave, my question to you is, what is the mechanical event that is caused by that? Atrial contraction, yes. And it would be occurring during which phase? End of ventricular filling, yeah? Does that make sense? End of ventricular filling. Okay, and then here's a question for you. Please get this right. Does this mechanical event, atrial contraction, cause the opening or closing of any valves? No, it does not. Yeah, it's just pressure of venous return that causes the opening of the AV valves. Are we okay? Okay, so the electrical event now is ventricular depolarization represented by the QRS complex. Yeah, QRS complex. Everybody with me? The mechanical event that is caused by ventricular depolarization is what? Ventricular contraction. Yeah, ventricular contraction. Good. Okay. Does this mechanical event and the pressure that it generates, yes, cause the opening or closing of any valves? Mechanical event, ventricular contraction, and the pressure that it generates. Does it cause the opening or closing of any valves? Okay, yes. Now be more specific and tell me what happens in what order because of that pressure change. What? Not semilunar first. What happens first? Close AV valves, pause, generate more pressure, and then open semilunar valves. Yes? And that's the order that it goes in. Yeah? I mean, you can, but you're probably going to croak. Okay? Everybody okay with that? So let me just do two clinical connections, and I'll have you guys do a think, pair, share, and then we'll go back and pick up some of the clinical stuff from before. Okay, so clinical connections. If you have abnormal electricity, you'll get abnormal mechanical activity. Yes? Okay. Should make sense to you. Cardiac arrhythmia is a really general term. It means it's doing something other than what it should do, which is atrial contraction, pause, ventricular contraction. Atrial contraction, pause, ventricular contraction, right? So that's just general what it should be doing. But there are a couple of different kinds, tons of different kinds. We're only going to go into a couple. A fibrillation is when the atria or the ventricles kind of spaz out and lose their coordinated activity. So this is fibrillating ventricle. So this is what it should be doing. I'm not coordinated enough to keep this going, but atrial contraction, pause, ventricular contraction. Atrial contraction, pause, ventricular contraction. Okay, fibrillating ventricles are when this one keeps doing its job and this one spazzes out. Yeah, and I can't do them at the same time. It's just not coordinated enough. But atrial contraction is when this one keeps doing its job and this one spazzes out. So which one is immediately life-threatening? Ventricular fibrillation, yes. because it's not relaxing, it's not filling, it will cause a heart attack because it's compressing the myocardial capillaries, and they will defibrillate you, either chemically or electrically, to get that going. Atrial fibrillation is what I have, and atrial fibrillation is not immediately life-threatening, although it is problematic. Ventricles are doing just fine, but when the atria go into atrial fibrillation, they're just spazzing out. It immediately drops my blood flow by about 20%, yeah, because you're not squishing it out, which can make me pass out, which is not necessarily life-threatening unless I'm driving, but I can usually feel it coming on, right, when we get off the road or whatever. I did pass out one time in phys in this class, and I was like, knew it was coming. I was like, I'm gonna pass out. Here's my husband's phone number. And then one of my students drove me home. It's really sweet. So my husband was in a meeting. He's like, I love you. I'm in a meeting. I'm like, how much do you love me, bastard? But the atrial fibrillation, the problem is really that if the blood sits in the atrium for a decent amount of time, it increases the likelihood of what? Any idea? Clots. Yeah. And so if you have a long bout of atrial fibrillation, mine are usually 30 seconds to 5 minutes, but I was in AFib for one time for 72 hours, and it increases your likelihood of a stroke, heart attack, and pulmonary embolism for weeks after. So I usually have to shoot myself up with anticoagulants for a couple of weeks after. And for that reason, I also had to, the whole time I was pregnant, because estrogen increases your likelihood of blood clotting, I had to shoot myself up twice a day during my entire pregnancy. But it was okay. I mean, because we're both alive. So, and then an ectopic pacemaker is, oh, son of a, I hate everything. An ectopic pacemaker is when there's a coup and something tries to take over from the SA node, right? It should go SA node, contract, tells the AV node to contract, and then the ventricles. But if you got some area of the heart that wants to do it faster than the SA node, it can make it discoordinated, and like the left ventricle will contract before the atria, or the right side goes before the left side. That's called an ectopic pacemaker. Ectopic just means out of place. And this causes premature contraction. Like if your ventricles contract before your atria do, then they're not going to be full enough. And this can be problematic. It's going to, of course, compromise blood flow. Caffeine and nicotine tend to make ectopic pacemakers worse. Sometimes they go in and do an ablation, in which they just burn off those misbehaving cells. But they weren't contractile cells anyway. They were pacemaker cells. So as long as you get targeted at it, it's probably fine. Okay, so with our last few minutes, let's go talk about hypotension and hypertension. Okay, so these are important because you're going to run into these when you are being a clinician. And you guys can just read about congestive heart failure. It's fine. I probably won't ask you a question about it. It's interesting though. So clinical variations in blood pressure. What is hypotension? That is when your blood pressure is low. When you're actually diagnosed with hypotension is when you have a resting systolic blood pressure of less than 100 millimeters of mercury. Okay. Is it necessarily problematic? Definitely not necessarily problematic. But again, when you're looking at hypotension, it's the top number that's going to be important, because remember, systolic over diastolic. The systolic number is immediately after ventricular contraction, which sort of represents the force moving forward, right? So mild hypotension is actually not particularly problematic. It's associated with a relatively long, healthy life, although, like Greta, if you get up really fast, you're going to get lightheaded. You can usually take care of that by just drinking enough water, and which is what I should do, and I'm trying. I've had 3 liters of water a day for the last 3 days. I don't even know how you people do it. It's gross. And you have to pee 6 times in every movie. What do you do with your life? I feel like all I do is pee. I've lost all my hobbies because I'm just peeing. I don't know how you do it. Like, tell me. I'm trying to be good, and it sucks. Okay, but if you get severe hypotension to the point where your organs, your capillary beds, are not receiving adequate blood, it's called shock. But circulatory shock does not mean, oh, I'm shocked. It means super low blood pressure, to the point that you're not delivering adequate blood flow to capillary beds. So it means something specific physiologically. So causes, well, pressure is heart, vessels, kidneys, right? Heart, vessels, volume, right? So causes of shock, heart, vessels, volume, yeah? Any of those could cause it. So Decreased cardiac output, maybe you had a heart attack, can't generate the pressure, heart, yeah? Massive vasodilation, because you had an allergic response or damage to the nervous system, yeah? So that would drop your pressure too, right? Loss of vasomotor tone. If you damage your spinal cord, the sympathetic nervous system can't keep vasomotor tone. Sometimes that's why people die after spinal cord injuries, is because you need your sympathetic nervous system to keep the muscle tone. Or septicemia or toxemia, when you actually get a bacterial infection that goes systemic, causing release of vasodilators that are usually local, but you release so many of the vasodilators that they cause systemic vasodilation, right? And you go into septic shock or toxic shock. And of course, most of the women have heard of toxic shock because if you were educated properly with the use of tampons, you know that the vaginal canal is not sterile, right? And the normal flora in the vaginal canal are totally fine as long as you do not let them accumulate and get a huge bloom of the normal flora, which you can if you're not using tampons correctly, and you can go into toxic shock. And then you can have a systemic response. And that is no joke, right? People die of it. They get amputations because of toxic shock. Or septic shock, because you are probably going to do wound care at some point. Why is it really important to care for wounds? Because what starts out local, can end up becoming systemic. And then not only can the immune system not overcome it, but you can go into shock because of it. And this is really important because you're going to be dealing with diabetics. Their immune systems suck, their cardiovascular systems suck, and they get a lot of wounds and they take a lot of care to heal. Severe allergy, like that kid in school. Anybody got a kid in their kid's school who's so allergic to peanuts that you can't have peanuts within 10 feet of them? There's like a peanut-free table at the school, right? That's because they go massive histamine release that causes systemic vasodilation and they go into shock. And it's happened twice with this one girl in school. So they are serious about the damn peanut thing, man. And everybody hates like sunflower butter. Sun butter, it sucks. It's grainy as hell. Loss of blood volume. If you bleed out, you don't have enough volume, right, to maintain. Hemorrhaging, dehydration, massive dehydration can also cause shock, like sweating, vomiting, diarrhea, diuretics, all of those kinds of things. This is the way, by the way, that some people who have eating disorders, right, anorexia and bulimia, end up dying related to it because they lose so much fluid, especially when they're taking diuretics, that they go in shock and they just don't wake up from it. Okay, and then hypertension, which is when your blood pressure, resting blood pressure, is 140/90 at rest. And that number changes every once in a while. So what's the issue with that? The issue with that is that your blood vessels get completely clogged up. So if you go to the doctor and they say, oh, why do I have hypertension? They may say, oh, it's idiopathic, which means it's really complicated and I have another patient to see. But they do know the answer. How do you get hypertension? It's a combination of your crap luck with your genetics, but that's not very much of it. It is primarily diet and exercise. And we are the poster population for cardiovascular disease. Usually reduced vessel radius because of arteriosclerosis and atherosclerosis in combination with vasoconstriction, which is related to stress. Okay, so what happens is it's asymptomatic for 10 or 20 years, but it's causing the problems as your vessels get gunked up and gunked up and gunked up because your P2 is increasing. So what does your heart have to do? It has to increase the P1, yeah? So it's wearing out the heart. In addition, it's putting a lot of stress on the vessels because they are at higher pressure over longer periods of time. So you're trashing your plumbing in the process. And that also causes injuring and scarring of the vessels because they don't get gunked up just smoothly. They're lumpy. And then when they stretch, they actually get scarred and more lumpy. And you get increased blood pressure damaging delicate capillaries in the kidney and delicate capillaries in the retina. So chronic hypertension causes kidney failure and can cause blindness. A lot of times those are associated, chronic hypertension associated with diabetes as well. And then you get an increased risk of stroke, both from thrombosis, which is just busting a hole in something because too much pressure. And then, thrombosis is clots, and then busting a hole in something with a hemorrhage, like a cerebral hemorrhage. So this is called the silent killer. I'm going to finish this, and then you guys can go. Well, you can go now if you want to, but I'm still going to talk. So what are the risk factors for hypertension? Stress, because it causes water retention with aldosterone and constriction, right? Heredity, you can't do a damn thing about that. Go back and undo your relatives. I mean, wouldn't we all like to do that, right? Specific ones. People of African descent have a higher predisposition to hypertension even with the same diet and exercise patterns. Obesity, your pressure has to be higher when there is more of you. Yes? Okay. High sodium, high fat diet, that's the American diet because freedom, pew pew. Lack of exercise, also the American way, freedom. Smoking, the entire South, right? They are pretty much just case studies in hypertension right there. My whole family. So treatment, what do? Well, you go into the doctor and you say, yeah, I've got hypertension. And he says, hey, you should change how you eat and you should lose some weight. But you don't want to do that. So you ask him for a pill. But what you should do is lose weight, if possible, restrict sodium in your diet, right? Moderate aerobic exercise, but not enough to cause you a heart attack. Reduce your stress, but then you'll skip straight to the drugs. And you'll say, how about a diuretic? Because that impacts volume, right? All of the drugs for high blood pressure hit heart, vessels, volume, okay? Diuretics decrease blood volume. A beta blocker prevents epi from binding to beta adrenergic receptors on both the heart and the vessels. So it hits heart rate, stroke volume. It also allows for vasodilation. Calcium blockers close the slow calcium channels in smooth muscle so they don't constrict as much. ACE inhibitors, our friend, inhibit that enzyme, and you don't get vasoconstriction and aldosterone release. Cool? So these are the major treatments. There are probably more now, but I'll bet you that if you find a new one, it's going to hit heart, vessels, or volume, right? Okay, so I won't test you on congestive heart failure. You can read it if you want to. Okay, that's the only thing that I didn't do. Oh, by the way, there's this cool GIF, whatever you call them. It's actually showing you all of the stages of the cardiac cycle. Kind of cool. Huh? I'll put it on canvas. Yeah. I mean, I like want it to slow down. I'm like, hey, pause. Because I'm like barely digesting what it just did, and then it goes on to the next one. But it's still kind of cool. What? Some of them, the ones that I have permission to post, are on the links page of melanieb.com. Yeah, so I think they are. Let me see.
One of the doors.
Low O2, low oxygen, high CO2, low pH, we just talked about this, were detected.
Muscle contraction. Yeah, they're right here, all three of them. Rupa, baroreceptor, chemoreceptor, and cardiac cycle.
That's different. That's different, because that's capillary bed, that's not systemic. I mean, it is, but it's not.
What's the question?
Capillary. The low O2, high CO, low pH, detected in the specific capillary bed will cause paracrine, AGCV.
Paracrine, that's local.
Local, so it would be dilation.
Yes, exactly. Good. Yeah.
Okay.
See this copy of this from here. Everything seems like.
I know, but I try not to look at those
Because if you can do it without looking, you actually understand it.
Yeah.
Yeah.
That's what I do first, and then I verify validation with.
And if you want to look first and then go without looking, you can